The Medcorp Raulerson internal jugular catheter for acute hemodialysis, hemoperfusion, and apheresis therapy has been designed with a unique curved configuration to alleviate patient irritation on the head and neck area, as well as problems with subclavian vein stenosis. The kit comes complete with one 18-gauge by 2 3/4 inch introducer needle, one .038 by 70 centimeter flexible J wire guide, one 12 French by 6 inch vessel dilator, one number 11 mini scalpel, one 3/0 silk curved needle suture, two injection sealing caps, and one pre-curved double lumen duo flow internal jugular catheter, available in 9 and 11 French diameter and 12, 15, and 20 centimeter lengths. This procedure is generally performed at the bedside. It must be performed under aseptic conditions. For this procedure, you'll need masks, patient as well as personnel, caps, gloves, and a rolled towel. It is recommended that hospital personnel and the patient be gowned to prevent any inadvertent splashes of blood. The patient is placed in the Trendelenburg position, and a rolled towel is placed at the base of the neck between the scapula in order to force the chest forward and allow the patient's shoulders to roll down. The patient's head is rotated to the left, assuming a right internal jugular vein insertion, rather than rolled or moved. Be careful not to angle the neck, so the cervical and thoracic spine are aligned, which will be used as anatomical landmarks. The upper right neck and chest are then prepped with betadine solution in a circular fashion, starting inwardly and moving outward in concentric circles to ensure adequate sterilization of the skin. The area is then draped using 3 or 4 surgical towels. The insertion site is then identified. The anatomical landmarks form a triangle at the right sternocleidoid mastoid muscle, 2 to 3 centimeters lateral, and the base of the triangle being the clavicle itself. Performing a skin wheel, the skin is anesthetized over the lateral angle of the triangle just above the clavicle using a 2% lidocaine solution. Next, a 3 to 4 millimeter stab wound is made with the number 11 mini scalpel. Now retract the skin on the neck slightly upward so the incision actually rests on the upper portion of the clavicle. This forms a better channel for the J-shaped catheter to pass through as it loops up over the clavicle and rests on the anterior chest wall. Then, using an 18-gauge by 2 3/4 inch needle and syringe, locate the right jugular vein. This is accomplished by retracting the skin rostrally as the needle is inserted and angling the needle approximately 30 to 45 degrees from the plane of the body and parallel to the long axis, aspirating as the needle is advanced. Usually the vessel is entered at about 2 centimeters. The deepest the needle has to be passed is about 3 to 4 centimeters. If there is no flashback, withdraw the needle and direct the point slightly more laterally, not medially. When the needle is directed more medially, the carotid artery can be inadvertently entered. Once flashback has occurred, the syringe is rotated 360 degrees in case the vein has been partially indented. The rotation allows the vein to spring back to its natural position and encompass the needle point. Now, aspirate to confirm a free flow of blood. Occluding the needle opening with a thumb, remove the syringe while the needle is still in the vessel. The guide wire is threaded through the needle and into the vein. If the guide wire passes from the right atrium into the right ventricle, it may cause ventricular irritability, ventricular tachycardia, or ventricular fibrillation. If these problems occur, simply retract the guide wire. After flushing and locking the catheter with heparinized saline, remove the needle while keeping the guide wire in place. Now, pass the vessel dilator over the guide wire, leaving it in place a few seconds to fully stretch the opening. Remove the dilator and be ready to pass the catheter back over the guide wire immediately, since there may be a significant amount of bleeding. The catheter is passed over the guide wire to a point that the tip of the guide wire is protruding from the venous hub of the catheter. Both are then passed as a unit into the vessel. Again, the EKG monitor is observed so that the guide wire may be retracted slightly if any ventricular irritability occurs. Once the catheter is fully seated, remove the guide wire and flush both lines again with heparinized saline. At this point, a chest X-ray should be taken to confirm the catheter location in the superior vena cava and to rule out an inadvertent pneumo or hemothorax. Once proper placement has been confirmed, suture the catheter in place at the rotating suture wing with the 3/0 silk suture supplied. PUP ointment is then applied to the insertion site, and a sponge is situated to run from the insertion site downward on the chest wall to prevent collection of fluid at the point of entry. Adhesive wound dressing is then applied, and the injection caps are placed on the catheter. The procedure is now completed, and the patient is ready for dialysis treatment. As you can see, the unique J design of the Medcorp Raulerson internal jugular catheter promotes patient comfort as well as technician ease in administration. Additionally, recent published papers describe the alarming rate of subclavian vein stenosis associated with subclavian cannulation. The Medcorp Raulerson internal jugular offers straight internal jugular approach. The pre-curved design keeps the hub and extension away from the patient's head and neck area, offering increased patient comfort. The unique luminal design has 360-degree arterial and venous port, eliminating the need for reversing of blood lines and reducing catheter occlusion caused by the vein.